I'm Dr. Steve Johnson, and welcome to Theories of Addictions. This is week 2, and the topic is the disease and public health model. This is lecture 2 in week 2, so I'm going to zero in on the public health model since we did the disease model in lecture 1. If we look at the public health model, it appeals to a very, very specific conceptualization of causation, or what causes addictive behavior. And in the public health model, it appeals to what's called the triad model of causation. The triad model of causation is based on a view of an interaction among an agent, a host, and the environment. They're all interconnected, and the interconnected influences on each other give rise to the addictive behavior. It is important to remember that each factor in that triadic model is a necessary condition. It has to be there, but no one factor is sufficient to cause addiction. We can't say that the host, the addict, causes the addiction. We can't say that the environment necessarily causes the addiction. It's the interaction, at least in the public health model. Each individual factor is a necessary condition, but no one factor is sufficient to cause the addictive behavior. In each of those factors, those 3 factors, there are actually many, many structures or components, or components of each factor. For example, let's look at the host, which in the case of drug addiction, the host would be the addict. The addict is made up of multiple factors, or there are multiple factors or components to that, to the host. One would be genetics, another age, belief system of the individual, belief systems, attitudes, life habits, and many, many other components. The public health model is also concerned about health and healthcare disparities due to environmental factors or conditions, chief of which is poverty. Numerous studies that look at health outcomes say that health outcomes are due to, by and large, to social, economic, and environmental disadvantages of an individual or group of individuals, often associated with race and ethnicity. So poverty is viewed as the root problem with associated problems of environmental disadvantages associated with race and ethnicity. Healthcare in the United States was designed to be distributed efficiently, much more than equitably. I think there's been movement within certain circles about the distribution of healthcare more equitably, but there's still an emphasis on efficiency in its distribution. Often the emphasis is on access rather the inability to use healthcare due to poverty. And we may have made great strides in access to healthcare, but still there are things, even though an individual may have access to healthcare, there may be conditions that prevent them from acting upon that access in helpful ways. The model focuses on structural weaknesses, such as the social inequality that exists among groups within the United States, or family instability in certain circles, or community instability due to economy and a number of kinds of factors, or again, lack of access to healthy food and healthcare. If you look at, for example, grocery stores, you'll find wonderful healthy food in the suburbs, but often in the inner city, we will see really small shops with not a lot of emphasis on fresh food, And so it makes the access of healthy food and health care a bit more challenging. And of course, then there can be unhealthy living and work environments. For example, crime and pollution, etc., within certain environments that we don't see in higher socioeconomic environments. There have been very, very important public health developments, and one of the really most important developments is what's called the National Vital Statistics System. This system is developed by the CDC, the Center for Disease Control in the United States. This structure, the National Vital Statistics System, permitted the United States, for example, to document that the opioid epidemic was a major public health challenge, and what were the features of that? That there was a rapidly escalating healthcare problem, and it contributed to a growing number of deaths, in alarming rates. For example, I was a therapist in a particular area, and it was kind of an economically depressed area. And as I was driving to the clinic where I did some work, I nearly every day when I would go in there, I would see stretchers being brought out with bodies there. And when I would inquire, sometimes it was due to a drug overdose and often with opioids. So major problems. So it's really helpful that we have the CDC tracking that kind of data so that we know what the problem is. Also, the public health model has generated some important findings. For example, age of onset of drug use, which is tremendously important because the earlier that someone uses the drugs, the greater the problems that the individual has throughout life. And then the development of what's called the gateway hypothesis. So, and I'll touch on both. The age of onset, when we look at that in the public health model, as I said, we see that early onset of drug use and abuse is linked to all kinds of problems. So one of these, and these have great social impact. One is conduct problems. Conduct problems can be seen in things like theft, crime, all kinds of issues, or lower socioeconomic status later on, poor academic performance, which greatly impacts one's future, or increased likelihood of developing an addiction later in life. So really deleterious consequences of early drug use. So in fact, there are programs that to try to, in particular areas with those challenges, to try to keep really young kids and children and high school age children from having access to the drug or using the drug. Let's look at the gateway hypothesis. This hypothesis looks at progression of drug use to harder drugs, from drugs that are not so hard to increasingly harder drugs. The gateway hypothesis hypothesizes that there's this predictable sequence of drug use in 4 different stages. Okay? The first stage is where the individual is using beer or wine or some combination there. And the second stage is then they move toward hard liquor and cigarettes. And we see that in these 2 stages, most of the individuals that engage in the use of them do not progress to stages 3 and 4, but some do progress to stages 3 and 4. Stage 3 would be typically the use of marijuana, and then stage 4, more illicit drugs, heroin, meth, etc. A larger percentage of those individuals in stages 3 and 4 progressed from 1 and 2. It's not typical for an individual just to jump into heroin use or jump into the use of meth. Frequently, they may have used marijuana before that or been drinking, etc., before that. So While not all in 1 and 2 do progress to 3 and 4, most in 3 and 4, a large percentage, were engaging in 1 and 2. So that if we can prevent access to those, then we will decrease the problems that go with deleterious drugs. Many people also are unaware that marijuana can have some pretty negative consequences for certain individuals. We'll again talk about that in another time. There are many, many criticisms of the gateway hypothesis. For example, those groups that want to legalize marijuana point out that this hypothesis may be a description, but it's not causal. We say in philosophy of science that although we may have a rule that describes something, it doesn't mean that it causes something. So that we, simply because this gateway hypothesis may describe what's happening, it doesn't necessarily get at causality. Why? Because there are multiple causal factors that may be involved in an individual progressing from drug use, right, etc. So we can't attribute it to this previous drug use. Also, public health, so this is really important. It's been a helpful research subject. My wife does research in this area, and the research is getting very, very refined. Public findings on the types of prevention programs is really, really important. And they do come out of this public health awareness, public health model to which we owe a debt of gratitude. What public health has found that in the prevention programs, in the drug prevention programs, they're usually based on a target population. So for example, they want to look at children, they want to look at teenagers, maybe they want to look at the elderly, etc. So they're looking at a target population. Also, they've become aware of two major categories that are tremendously important. I'll talk about it from a personal view in just a minute. They have found that there are definite protective factors as well as risk factors in developing an addiction. So for example, my specialty is conceptualization and treatment of post-traumatic stress disorder. And remember, I said that one of the co-occurring disorders with post-traumatic stress disorder is substance use disorder, as well as major depressive disorder. So one of the things that we know in looking at the development of post-traumatic stress disorder is that there are risk factors, factors that if there will predispose an individual in the face of a trauma to develop post-traumatic stress disorder. And there are also protective factors. If you have those, then that will prevent you or make hold you back from developing the disorder. So we see the same thing then with drug use and engaging in an addiction. That there are certain factors in place that if they're there, we will see that will help the individual not to develop an addiction. But if there are also risk factors that will increase the likelihood of that. Knowing that is tremendously important because we can use that information to have programs that have those protective factors in them and can change the risk factors, decrease the risk factors. These are often, they often address in evidence-based prevention programs. I do want you to look at the website for SAMHSA because it will have many of these prevention-based programs. SAMHSA is S-A-M-H-S-A, SAMHSA. I'd like for you to study in detail the following 3 programs, which are discussed in your text, and you'll be able to perhaps find them on the SAMHSA website and elsewhere. These three programs that I want you to look into and be ready to discuss are the Life Skills Training Program, the Life Skills Training Program, fascinating program. Secondly, the Guiding Good Choices, which has parent and school involvement, community involvement. And three is the Project Toward No Drug Use. There are challenges to actually, these are great programs, but there are challenges to the dissemination and implementation of these public health community-based models, okay? And I think it's really important for us, and public health has studied what these factors are. One is there's a problem with the diffusion of information. We already saw in another lecture, I mentioned that we know a lot about what works to helps an individual in terms of treating their addiction, but that information has not been disseminated or has not been trickled down to the general public or our elected officials. And so what's going on with this diffusion of information? Well, we see that new models are often adopted very slowly, even if they have major advantages over the older models. What helps adoption then is the question. And I think it's something for us to think about. One thing that helps is if we explain the advantages over other models. We can't stop there, but that's one thing. Why is this model more helpful than some other models? Secondly, though, we have to show compatibility with the values, the past experiences, and the needs of the individuals who may need these services. We have to, if the model or the program doesn't seem to reflect the values of the individual in the community, there's a poor chance that it will make it. Or if it doesn't cohere with their experiences in life or what they view as their needs. The third factor is what's called trialability. That means that the model should be of a nature that it could be experimented or tried easily, that there's not this huge hurdle to try to get it off the ground within a community. If there is that huge hurdle, the likelihood of it being adopted will go down tremendously. And then fourth, there needs to be observability. Observability of what? You got to show that the outcome of adopting the model, the outcomes are observable. Observable to whom? To the people in the community. They need to see this person or these individuals coming from these programs, they're acting different behaviorally, right? They're acting like different people, their behaviors, they seem healthier and happier and all those kinds of things. We need to see observable changes. Well, there have been a number of community-based interventions that have been tried. And we do know something about them in terms of their strengths and use, okay? So let's just look at some of these. One is most of these programs do result in lowering of substance use and related problems. Related problems might be this. So the substance use might be drinking alcohol. The related problem might be drunk driving, and the wrecks that are caused from that and the death, etc. So, so most of these programs do cause a diminution or a lowering of the substance use and related problems. However, the effect size is often really small. The effect size means what kind of difference in behavior do we see? And if the effect size is small, we're not seeing a lot of change. So it may work, but the amount of change may not be great. And so there can be a problem. If community leaders say, or politicians or whatever, think, the expense of implementing this isn't worth it based upon the low level of change that we see. So that can be what is one thing that has been learned. The third thing is related to something that I said in a previous lecture, and that is that substance use, education, and awareness alone tend not to work. We've got to go beyond just education of one sort. We've got to go beyond just helping them gather cognitive information about drug abuse and use and the consequences thereof. Outcomes are better if we focus also or additionally on behavior. Not behavior only, but cognition and behavior, as well as emotions. Outcomes are better in the community for these programs if the community embraces the program and the program is not seen as imposed by strangers from outside the community. So as you can see, we've gained quite a bit of information from this public health model, but some of it has not been fully implemented, but is in process. So I do want you to go check out those programs that I just checked. So thank you all very much. We have finished week 2. In week 3, we'll be focusing on some really kind of exciting topics, and those would be psychopathology, addictions, and their co-occurring disorders. I already talked about some co-occurring disorders like major depression, trauma, etc. So we're going to look at those in week 3. So goodbye and have a good day.
I plan to use my degree ultimately just to help people. I'm here to find out specifically what demographic that is.
The professors really take the time to look at the courses and how they're going to prepare us to be counselors.
I'm just really excited to get to learn from these people that have so much experience in this field.
It's obvious that they have a passion for what they're doing, not just because they enjoy it, but because they know they're investing in someone else, and that's most important to me.
I ultimately chose CIU because of the community. I love the fact that I know that I will be with the same people for the next 3 years.
We have a time during our classes where we get to be in small groups, and that allows us to get to know each other and to support one another and to learn together. I feel like I'm right where I need to be, and I'm grateful to get to be a part of this program.